Okay, so I have nothing to disclose. I put some questions on here which are pertinent to some of the topics I'll be talking about. The first question, are patients who are hepatitis B surface antigen positive who need liver transplant and get a liver transplant, do they require no prophylaxis because liver transplant is curative? Are they treated with nucleotide or nucleoside antivirals only if there's evidence for recurrent Hep B? Do patients require 1 year and then after 1 year, the risk of recurrence is low, so we stop treatment, or do we receive lifelong treatment with either a nucleoside or nucleoside agent along with HBIG, which is Hep B immunoglobulin for a length of time which varies from center to center. Second question, African Americans have a lower risk of dying from end-stage liver disease compared with other races. True or false? And third question, frail patients should be excluded from liver transplantation due to poor outcomes. So the first abstract I'm going to present actually was from AASLD, and it was a very interesting abstract. This is an oral presentation. Early liver transplantation for severe alcoholic hepatitis not responding to medical treatment, results of the French-Belgian prospective study called the QuickTrans study. And basically a little bit of background, most of us know that patients with severe ALK-HEP who are non-responders to corticosteroids have a very poor prognosis without a liver transplant. And the Lille model was developed in France several years ago. And if you just plug in some simple numbers, which are here at baseline, and then bilirubin at day 7, after starting corticosteroids, you can predict 6 months survival. And if the score is above 0.45, there's about a 25% survival at 6 months. The primary aim of the study, though, was to assess non-inferiority of 2 groups with regard to alcohol relapse. One group, I'll actually show you right here. So group A, these are real non-responders. There were 78 patients, and these patients were considered good transplant candidates based upon a modeling that they developed. And their median Lille score was 0.86, again, a very poor prognosis. They compared this group to group B, which was patients with alcohol-related cirrhosis, whom they deemed good liver transplant candidates. They needed to be sober for 6 months, and there were 93 patients. And then they did some other analysis comparing group A to group C, which was patients with severe ALK-HEP, non-transplant candidates based upon their modeling. And they also had very poor Lille scores with a poor likelihood of survival. So again, the primary analysis was to assess non-inferiority of group A to group B with regard to 2-year alcohol relapse. And they actually found that they could not prove non-inferiority because there was an increased risk of alcohol relapse in the patients who received liver transplants for ALK-HEP who were non-responders compared with the alcoholic cirrhotics. They also found heavy alcohol relapse rate at 2 years was significantly higher in the ALK-HEP group. However, the 2-year survival was really no different. This was a secondary endpoint, the two-year survival. They also compared the survival of group A with group C, and group C again was the ALK-HEP group that did not get transplanted, and what makes sense is there was a significant decrease in survival with what they call the medical management group, the non-transplant patients, 83% versus 28%. And again, that's not a surprise. So the conclusions were that they could not show non-inferiority in terms of the alcohol relapse between the 2 groups that I mentioned. But despite that, there was no difference in survival, and liver transplant for a selected group of patients with ALK-HEP does provide a survival benefit, and it should be considered. In the green, I just have some of my comments. These are very selected group of patients. They get worked up very stringently. They get followed very stringently after their transplants. And is this really translatable to the typical liver transplant center? And then what happens after 2 years? Because if there's such a high risk of heavy and moderate alcohol use after transplant during the first 2 years, obviously that may translate into worse outcomes later on. So I think the jury's out a bit on that. The second paper, which is also, this is from AASLD as well, which I thought was interesting, MELD subtypes and waitlist mortality. Is a MELD score of 25 driven by creatinine, the same as a MELD score 25 driven by bilirubin or INR. And they determined, we all know that the MELD score is the major determiner of waitlist mortality that we use in terms of priority for listing patients with liver transplantation or for liver transplantation. Their hypothesis was that if the MELD is predominantly driven by the creatinine, that those patients have higher waitlist mortality and dropout. So they had basically 3 groups. If the MELD was driven by at least 50% weight by either creatinine, bilirubin, or INR, they called it the MELD, whatever that was. So if it's creatinine, then it's a MELD creatinine. If it's MELD bilirubin, then it's the MELD BR, and then if the INR is a higher weight, then it's the MELD INR. And the other components had to have a less than 35% weight. Now, interestingly, this was 2016 to 2018. Most of 2016 was after the MELD sodium was initiated, but they didn't mention sodium here. And then I looked at the relationship between the MELD subtype and waitlist mortality at 90 days. So these are the number of the patients. They had quite a few patients. They did find that the highest waitlist mortality was for the MELD creatinine, which is what their hypothesis was. And really for MELD creatinines that were or MELD scores that were between 25 and 34. And the liver transplant rate was actually significantly lower for patients who had a MELD creatinine at the 25 to 34 range of MELD scores versus the MELD bilirubin. And the hypothesis there was that these patients were much sicker and more likely to fall off the wait list if their MELD score was predominantly driven by creatinine. They also found, which is consistent with a lot of other studies, that women had a higher waitlist mortality compared with men. And for a MELD creatinine weighted score, the waitlist mortality for women was 15% compared with 11% for other subtypes, and the liver transplant rate was lower. This just shows for each subtype that women did worse than men in terms of rates for liver transplantation. So their conclusion was that all MELD is not created equal. The MELD creatinine has the lowest transplant rate and poorest survivals. The lower transplant rates and higher waitlist mortality was across all MELD subtypes. And in adjusted models, women fared less than men, even when height, weight, MELD, and diagnosis were accounted for. And a couple of comments here. Number one, if this is the case, then should MELD creatinine, especially if the MELD creatinine is less than 35 and perhaps above some other number, should those patients receive a MELD exception of some type? And again, this sort of reiterates the issue with women, that yes, women have higher waitlist mortalities than men. Creatinine is certainly perhaps part of that, but there's a lot more to that, and there's certainly a lot of interest in accounting for women having higher waitlist mortality than men. This is a very interesting study. This was also an oral presentation, AASLD, during the second transplant session, oral session. Prospective study of HBV cccDNA kinetics reveals very early graft infection despite NUC plus HBIG prophylaxis. And the reason I wanted to present this particular abstract was because I think it tells us a lot about the sort of what happens with hepatitis B and the fact that hepatitis B really is a chronic disease, even though we think we've cured it. And this is sort of, I think, a very good example of that. So a little bit of background, the low risk of HBV recurrence post-transplant is due to hep B immune globulin, which we give during the anhepatic phase after we take the liver out, and somebody who's hep B surface antigen positive. And then we give them daily for some amount of time after transplant, and then each center has its own protocol for how long to continue that. So first it's given intravenously, then it's given either subcutaneously or intramuscularly. Nucleotide and nucleoside prophylaxis is also provided, and the recurrence rate is less than 10%. Before we had the ability to give these medications, actually Hep B was not even a disease that was transplantable because the recurrence rate was so high and the death rate was so high. Again, there's a debate on duration of double prophylaxis, but every center would continue at least the nuke prophylaxis. The problem here is there's a lack of non-invasive biomarkers to detect intrahepatic replication, so you really can't individualize treatment decisions. If you could prove that there was absolutely no intrahepatic hepatitis B, perhaps maybe you would, that would affect how you would prophylax, especially in the long term. So the aim of the study, or aims, analyze cccDNA kinetics after transplant and determine if serum biomarkers correlate with intrahepatic cccDNA. So cccDNA is sort of the Achilles heel of Hep B, or at least for us. It's the DNA that is responsible for viral persistence. So nucleoside and nucleotide agents, yes, you can drive down Hep B DNA to undetectable, but you can't get rid of this particular subset of DNA, which then allows the virus to replicate once you stop the drug. And that's why it's almost unheard of for patients to actually become surface antigen negative on oral nukes. It's a very, very low rate because you can't get rid of that cccDNA. The Hep B core antigen is something that actually is in the blood. It's not a routine blood test that we can order. It's a very specialized test, and it correlates with intrahepatic cccDNA activity. So what they did was on the day of liver transplant, and then post-transplant at 12 months, they drew blood. And they checked for routine surface antigen, Hep B surface antibody, Hep B DNA, bilirubin INR. And then they did these ultra-sensitive tests, which I'm not going to go into, for Hep B surface antigen and Hep B core antigen. And again, these are not tests that are routinely available. They also biopsied the native liver. They biopsied they took a sample of the liver after reperfusion, meaning after you take the liver out, and then they biopsied the new liver right after reperfusion. So that's where everything's connected, and you're flushing the liver now with the actual blood from the portal vein hepatic artery from the recipient. And then they did the same thing at 12 months. They re-biopsied the patients at 12 months. So in the HBV group, the control group was just patients who were Hep B core antigen, Hep B core antibody negative, no evidence for, and surface antigen negative. And so in the Hep B group, they all received nukes. This is the breakdown. Most of them received entecavir or tenofovir. They didn't specify which tenofovir, and a few were on lamivudine. Everybody got HBIG for a median of about 400 days, and all the donors were Hep B core antibody negative, meaning no evidence for exposure to Hep B in the donors. So what they found was by conventional surface antigen testing, everybody was undetectable at 1 year. 5 of 20 patients were positive for the ultrasensitive assays, and the core antigen was detected in 12 patients. So this basically means that 1 year there was evidence for hepatitis B. This is in the blood. When they actually looked at the sample from the liver, they actually found that there was significant Hep B in many of those livers, either cccDNA or total DNA or a combination. But really the bottom line is that they weren't able to correlate the DNA of any type or RNA of any type in the liver compared with in the blood. And so they really did not have a way of determining by simple assay in the blood if somebody actually had DNA in their liver. And that's a problem because you're not going to, first of all, they're very specialized tests on the liver to determine if that DNA or RNA is present in the liver. And number two, you'd be putting people through a liver biopsy. And number three, and probably most importantly, there's really no data to prove that this would actually make a difference because those studies haven't been done yet. So their conclusion was, which is really interesting, rapid infection of the liver allograft by Hep B occurs despite HBIG and nucleotide or nucleoside agents. 1 year post-liver transplant, about 50% of patients had detectable Hep B markers in the liver. There's no correlation between the pre-liver transplant serum testing and the risk of having Hep B markers in the liver at 1 year. And the issue here is, at this point, you'd want to consider, should you change the Hep B prophylaxis protocols? You would like to be able to do that based upon simple blood tests. Number one, you can't do that because it doesn't correlate. Number two, this sort of methodology isn't really readily available. And number three, we really don't know the clinical implications of any of this. So I think maybe in the future, we'll be able to make long-term decisions, because we do have patients, who are fairly young, who have Hep B that get transplanted, and we're talking about lifelong medications at this point, and perhaps at some point, maybe we won't need those anymore, but this is way, way early. This is an interesting paper interesting abstract. Frailty, mortality, and healthcare utilization after liver transplant from the Multicenter Functional Assessment in Liver Transplantation, the Frailty study. And this is a AASLD abstract as well. We know that frailty has an adverse effect on outcomes in cirrhotics waiting for liver transplant. We know that they have worse waitlist mortality, higher waitlist mortalities, worse survivals in cirrhotics in general. But how does it affect post-liver transplant outcomes? So this is the frailty index. And again, we're looking at grip strength, doing chair stands, and then balance. And they come up with an index which is actually very well validated in terms of how a cirrhotic patient will do. But it hasn't been really validated in sort of post-transplant outcomes. So the methods they use, the frailty evaluation from 8 US centers, 2012 to 2019, using this frailty index, and they determined above or equal to 4.5 defines frailty. And I'll just go on to the next slide. So what they found was that in patients who were non-frail, they actually had better survival at really going out to 60 months here, so 5 years, compared with patients who were frail. Their determination was that really expeditious liver transplant after identifying and intervening on frailty may actually improve liver transplant outcomes. Oops. The question that I have, though, is, in patients who are frail, there are certainly you can't change their gender. But in terms of some of these other issues, how acutely did these come on? We all see patients that come in the hospital or come to our clinics who have been in a wheelchair for 3 months. Then you have the patient who really just became pretty frail very recently. And the question is, you need to somehow determine which category these patients fall into. But I do think this is really good evidence that the patients really do much better if they're not frail. I didn't mention the post-transplant ICU stays and utilization of resources, but they are higher in patients who are frail, which kind of makes sense. The next paper or abstract was from AASLD. African Americans have unequal access to listing for liver transplantation in the United States. And there's a lot of interest in disparities in healthcare in general, and certainly regarding liver transplantation. And I think this is an important paper because it outlines some issues that I think are very important. We know that there's racial and ethnic disparities. While MELD eliminated racial disparity in waitlist outcomes, there are data to support that there is disparity in liver transplant listing. And if we're not listing patients for liver transplants, then we're going to have an increased risk of dying. The study aimed to evaluate patients listed for transplant who undergo transplant or who die from end-stage liver disease, stratified by state and by race and ethnicity. So they used 2 databases, the CDC Wonder, which gives national data on mortality and causes of death, and also the UNOS database, which is the database that we use in terms of patients who were listed for liver transplantation and all the data that is submitted there. They looked at states with an active liver transplant program during each year of the study. patients from age 25 to 64, 2014 to 2018 who were listed or who died of end-stage liver disease. So that was the period. The primary outcome was listing to death ratio. Secondary outcome was liver transplant to listing ratio and liver transplant to death ratio. And they analyzed ethnicities, multiple ethnicities, as well as white, Black, Latinx, and Asian. So what they found was that while patients actually who got listed for liver transplant who were African American actually got transplanted at a very high rate, there was actually increased risk of dying and not getting transplanted. So there's a disparity in African Americans. So there's a decreased registration rate compared with other ethnicities and or races. And so there is a disparity there. And we need to identify causes so that we can intervene and try to get patients evaluated for liver transplant. So again, they do very well if they get transplanted, but the transplant rate is low. This is another abstract from EASL. Early recurrence of HCC after liver transplantation can be predicted by FDG PET and microvascular invasion explant pathology. And this is from Italy. A little bit of background. Obviously, HCC recurrence is, again, the Achilles heel of liver transplantation for HCC. It occurs in probably about 15% of patients, but it really depends on a lot of characteristics about the tumor and also the patient. The tumor burden, AFP, pre-transplant, and features on the explant such as microvascular invasion, so certainly invading small portal venous structures or lymphatic structures, certainly macrovascular invasion, which would be invading the left or right or main portal vein, and tumor burden certainly may predict recurrence. So the aim here was to see if there are predictors of recurrence after transplant, and including FDG PET. So it was a single center study from Italy, retrospective. They used consecutive patients transplanted for HCC between 2010 and 2019. They had 182 patients, 84% male, median age 58, most at that point Hep C antibody positive. And 29% of these lesions were FDG avid. And the median AFP was, at liver transplant was 9. The range was 1 to 60,500. It's unclear if this was known, these higher numbers on the range were known at the time of transplant, if they were drawn, and then the patients were transplanted. So on the explants, 86% had at least one nodule with a viable tumor. This was the median size, that's 22, this is from 1 to 22, so up to quite large. 16% had microvascular, 16% had microsatellitosis, meaning that there are multiple small lesions adjacent to the main lesion, or at least one satellite adjacent to the main lesion. And 27% had vascular invasion. In terms of HCC recurrence, they saw 16%, which was 29 recurrences. The median follow-up was 42 months, up to 118 months. The probability of recurrence was 5%, 11%, and 15% at 1, 3, and 5 years. 13 of these recurred at 12 months, and they called this the early recurrence group. And 16 recurred at greater than 12 months. In terms of the survival, 64 months in the late recurrence group, and 104 months in the non-recurrence group. And I don't have the survival in the 12-month group on here. Must have fallen off. But I think it was 24 months for the recurrence within 12-month group. So risk factors associated with early recurrence on univariate analysis: microsatellitosis, microvascular invasion, FDG PET positivity, and if the lesions exceed the Milan criteria. In terms of independent risk factors on multivariate analysis, the microsatellitosis fell off, microvascular invasion and FDG PET positivity were the only two. So if they exceeded Milan criteria, that fell off. So again, if you have microvascular invasion and PET positivity, that's especially predictive of early recurrence. Interestingly, there was no mention at all of AFP. They didn't also mention the time on the wait list. And we have many patients certainly here who sit on the wait list with HCC for a couple of years. And oftentimes they get local regional therapy, they get local ablative therapy, they get maybe systemic therapies before transplant. They may have wandered in and out of Milan criteria. They may have had multiple different lesions that popped up, got treated. And again, we don't really know much about the other characteristics of these patients. And we don't usually do PET scans on our patients, but this is certainly something that's an interesting thing to consider doing. It's expensive, and traditionally we talk about the fact that FDG PET positivity is probably about or less than 50% on the primary tumor, may have some validity in terms of looking for metastatic disease if we suspect metastatic disease. This is another multi-center study, and I thought this was interesting because this is a hot topic right now, and I didn't see too many papers on this, abstracts on this topic. So anyway, prospective multi-center study of sofosbuvir, opatosvir, SOFVEL in Hep C negative liver transplant and kidney transplant recipients receiving organs from HCV viremic donors. Again, worldwide, the opioid epidemic has resulted in potential solid organ donors who are young, healthy, and Hep C viremic. I think the young and the healthy is really certainly important from the standpoint of liver transplantation. When you talk about heart transplant and kidney transplant, you're talking about low risk of having cardiovascular disease, lower risk of having diabetes, and so you actually have healthy organs. The newer agents, the DAAs, especially the ones that we're using now, are all pan-genotypic. They can be used in some cases in patients with renal failure, and it's almost 100% cure rate. And we know that in post-organ transplant patients, we can use these drugs, and the patients not only do very well in terms of SVRs, but they also do very well in terms of side effects. And even though many of the drugs have some drug-drug interactions, you can always either mitigate that with using a different combination or potentially using a different drug, such as maybe not using amiodarone if you're going to be using sofosbuvir, if you really need to use sofosbuvir. Numerous studies, and I put some of the references at the end, which will be on the slide set, in recent years have shown promising results with DAA treatment on these patients after transplant. But the key is you have to have prompt DAA availability, and that could be a problem. So anyway, the aim of the study was to evaluate the efficacy and safety of SOFVEL for 12 weeks in HCV non-viremic liver transplant recipients that are getting organs from Hep C infected donors. So there were 6 transplant centers. They were listed either for a liver transplant, a kidney transplant, or SLK, so no other multi-organ transplants. They also could not be Hep B infected or HIV infected, and this had to be a first transplant, no retransplants. For livers, they had to have, they couldn't be over F1. And for kidneys, they had to have a donor quality index greater than 85%. And the SOFVEL was started once viremia was confirmed post-transplant, provided that the patients were stable. So 115 patients were consented, 23 were transplanted, 12 liver, 11 kidneys. This is the mean age. I'm sorry, this is the mean age of the donor. This is the mean age of the recipient. Recipient mean age was 54, and think that 57% were male. Donor mean age was 38, 78% were male, 74% were donation after brain death. The remainder were donation after circulatory or cardiac death. And this is the breakdown of the genotypes and the mean or the median log HCV RNA at day 3. And it turns out everybody was viremic by day 3. And the bottom line is the patients received, again, 12 weeks of soft bell. All of the patients achieved an SVR. The only serious adverse event was actually one episode of antibody-mediated rejection in a liver transplant recipient who received an A2 to O. A2 livers express very little A antigen, and so you can give that to an O. So it's effectively like an O. But there is some data that these livers are at increased risk for precipitating antibody-mediated rejection. There was an SVR, again, in all the patients. Interestingly, 2 of the kidney transplant patients had detectable HCV RNA at the end of treatment, and they still were end of treatment responders. So the conclusion was that 12 weeks of this treatment is very safe, it's very effective. All the transmitted infections were detected at 3 days after transplant. They noted that the viral kinetics were different between the livers and kidneys, higher viral loads in the livers, and the recommendation was early treatment initiation is important. While safety is excellent, we have to be cautious of immune complications. And if we look at prior studies in hearts, in lungs, in livers, and kidneys, there are some studies that have shown increased risks of both T-cell and antibody-mediated rejection. There have been also some cases, especially where there was a delay in treating the recipient for Hep C post-transplant, where patients developed some kidney issues related to hepatitis C. And so really starting early seems to be the way to go. We need to be able to guarantee access to DAA therapy, because obviously we're giving a patient an infectious disease and we need to be able to treat them. And in some cases, it's although very uncommonly, it may be hard to get the treatment. So you want to know before you do this that you're going to be able to get treatment or get a guarantee from your hospital that they will cover the treatment. And there are no long-term data because this is really a new thing that we're doing. But again, it can be very life-saving for selected patients. This is I felt like I needed to at least have one abstract on COVID. We're going to have a talk later on COVID, so I didn't really include a medical or outcomes kind of abstract, but this is more about access to transplant. So we know that COVID-19 disproportionately impacts ethnic minorities with a geographic distribution. Historically, ethnic and regional variation exists across the country related to liver transplantation. So the aim was to determine the impact of COVID-19 on access to liver transplantation. So the method, they used the UNOS database, identified all patients over 18 who received a solid organ transplant, so not just liver, between February and June of this year. Ethnic groups are captured in UNOS as ethnicity, characterized as white, Black, Hispanic, Asian, Pacific Islander, and American Indian Alaska Native. So the peak COVID period was in April, and they saw a 38% reduction in solid organ transplant, with the impact least on liver transplantation. Among liver transplant recipients, there was a decline only in these regions which were heavily affected, especially early on during COVID, certainly Region 9, which includes New York City, Region 1, which includes New England, and Region 6, which includes Oregon and Washington. There aren't liver transplant centers in Idaho and Wyoming, but there are other transplant centers. So in terms of the ethnic, interestingly, the number of transplants diminished and then quickly picked up in May and June. I think this sort of parallels what we saw going on around here. But we really didn't see ethnic variation or racial variation in terms of people that were getting transplanted. So I think that was very, very encouraging. So the conclusion was, again, regional variation, those were COVID hotspots. And despite reports of disproportionate impact of COVID on ethnic minorities, we didn't see that impact on liver transplant recipients. This is another study. This is, again, AASLD abstract, liver transplant center size and the impact on clinical outcomes and resource utilization. And this was multi-center. Maria Stepanova is from the Center for Outcomes Research in Liver Diseases, I believe in Washington. So the background outcomes of liver transplant may be affected by transplant center volume. The aim was to compare outcomes of patients who are on the transplant wait lists in between low, medium, and high volume centers. So LVC is low volume, medium, then medium volume center, and high volume center in the United States. So they extracted data from the SRTR, which is the Scientific Registry of Transplant Recipients, between 2008 and 2017. The number of transplant centers was 139, and they characterized low volume being less than 40 listings per year, not transplants per year, listings per year. Medium, 40 to 100 listings per year, and high volume, greater than 100 listings per year. Waitlist outcomes that were investigated, either receiving a liver transplant. So if they didn't receive one, then they looked at death or too sick for a liver transplant. Transplant when transferred to another facility, indicating that either the complexity was high or the risk, they were more risk adverse and wanted to send the patient to a different center. And then the length of stay, which they thought corresponded to resource utilization. And then, of course, post-transplant mortality or outcomes from the transplant itself. So what they found was that, yes, outcomes varied by transplant center category. And you can see here, this is the high volume center. These are the percentage of patients on the list getting transplanted compared with the low volume center. They noted that listings at a high volume center was independently associated with receiving a liver transplant, and the length of stay at a low transplant center was actually shortest, which I thought was very interesting. The short-term mortality post-liver transplant was higher in low volume centers, but the same for medium and high volume centers. The liver transplant at low volume centers was associated with a higher post-transplant mortality overall. Also, it was interesting that the patients at the low volume centers were less likely to have private insurance, and also more likely to have patients that are on Medicaid or have VA insurance. So their conclusion was that center volume may impact outcomes and resource utilization. This addressing limitations may improve outcomes, and understanding the effect of center volume may impact funding and policy decisions. And just speaking for our own center, we're a high volume center at USC. We have a specialized ICU, we have a specialized unit on the floor, and certainly in terms of resource utilization, we have very specialized nurses and staff and physicians that take care of those patients. But I suppose at some low volume centers, they may be sharing resource, and that may have some effect as well. This is an oral presentation AASLD, and I wanted to thank Dr. Sundaram because he actually provided me with some of the slides that I'm going to show. Timing of liver transplantation for grade 3 acute on chronic liver failure using a dynamic model. And the sort of background here is that ACLF is a syndrome of organ system failure and severe systemic inflammation in the setting of decompensated cirrhosis. So you basically have to have some decompensation and then have other organs that are failing. So grade 1 is single renal failure, non-renal failure with renal insufficiency, or non-renal failure with encephalopathy. And I'll show you a little more about this. Grade 2 is 2 organ system failures, and grade 3 is 3 or more organ system failures. And we're predominantly talking about grade 3, which is 3 or more organ system failures. And we know that the mortality without a transplant is as high as 80% within 28 days. So when we look at the sort of the definition of acute on chronic liver failure, we're looking at, again, a decompensating event, so either ascites, portal hypertensive bleed, usually variceal bleed, spontaneous bacterial peritonitis, plus kidney failure, which is a creatinine greater than 2, or on renal replacement therapy, or kidney dysfunction with other organ failures. And that could be circulatory failure, so you need to be on pressors, respiratory failure, which yeah, in this study and most of the other studies that have used large data sets, the surrogate for respiratory failure is being on a ventilator. Cerebral failure, which is greater than or equal to grade 3 portosystemic encephalopathy, and coagulopathy, which is an INR greater than 2.5. So
again, it's clear that transplantation for patients with severe
whoops.
non although it is
sorry guys. Okay. So the things that are really important in terms of post-transplant survival are really three things: the timing of the liver transplant. So obviously, if somebody's very sick, you want to get a transplant as soon as you can for them, and that impacts survival. The donor quality, we often look at fatty liver, we look at older patients, patients with more comorbidities, abnormal liver tests and how long that's been going on before their transplant, donor sodium, and some other aspects. And then the ability of the other organ failures to recover. So for instance, somebody coming off the vent, somebody's encephalopathy getting better, somebody coming off of pressors. And you really have to balance these three aspects. Otherwise, and that's sort of how you determine if you think that somebody is likely to survive the transplant. And at some point, there becomes medical futility where the patient is too sick, the donor quality may be bad if there's an offer, and you know that their waitlist mortality is very high, but their transplant mortality is very high. So the question is, how do you decide whether or not to accept a marginal liver? And the aim here was to determine if you can figure it out that within 7 days of listing, they have ACLF3, you want to maximize 1 year survival. How do you make that decision? Take a marginal liver or wait for that perfect liver? So their methods were the UNOS registry 2005 to 2017. They used the ACLF. ACLF was defined using the EASL Cliff criteria, which is what I mentioned at the beginning. And mechanical ventilation was a surrogate for respiratory failure. Marginal quality organ was defined as a donor risk index, which is just a way we look at livers of at least 1.7. And then they subcategorize at less than or greater than equal to, greater than 60 or less than or equal to, or less than or equal to 60. ACLF 3 organ failures or 4 to 6 organ failures. So ACLF 3, which would be 3 organ failures or 4 to 6 organ failures. We know that in patients who have grade 0 to 2 acute on chronic liver failure, this is the transplant survival probability. This is grade 3, but if you can actually at listing, but you actually can get them down to a 0 or 2 organ failures by, say, improving their respiratory status, improving their encephalopathy, getting them off of pressors or whatever the parameters that were abnormal. Then we go all the way down here, and this is grade 3 at listing and at liver transplantation. You can see that their post-transplant survival probability significantly declines, but it's still within what we would consider acceptable range to consider transplanting somebody. And I think that's an important thing to consider here. In terms of non-transplant survivability, the findings here that if you're over age 60 and you have ACLF3, your non-transplant survivability is actually poorer than if you're under the age of 60. And similarly, if you have at least 4 organ failures, your survivability without a transplant is lower than if you have 3 organ failures. So that seems to be an important cutoff here. And in terms of post-transplant survival, again, if you're less than or equal to 60 and you get a great liver, this is your survival. Going down to here, if you are over 60 and you get a marginal liver, this is considered, this is the 1 year survival. Again, pretty low. If you look at if you look at here in terms of the number of organs failing, obviously, if you have fewer organs failing, your survival is going to be better. If you have 4 or more organs failing and you get a marginal liver, your survival is going to be very poor. So again, this is 3 organ failures with a marginal liver. This is at least 4 organ failures with a marginal liver, and this survival actually after transplant goes down significantly. We do know, though, that within 1 week of listing for liver transplantation, the chances of actually being upgraded to a ACLF 2 or below is only about 10%. And so most of the patients, you really need to make a decision very, very quickly because their survival is going to be very low. So anyway, their conclusion was earlier transplant is favored in the setting of ACLF 3, especially in patients that are over 60 or with 4 or 6 organ failures, because the faster that you get that liver into them, the more likely they're going to do well. Due to the combination of high non-transplant survival, low likelihood of improvement of organ failure before transplant, and a low relative reduction in post-transplant survival with a marginal quality organ, the idea is you probably just want to give them that organ. Some of the issues, of course, this is retrospective, it's database querying, which depend on the fidelity of the data that's inputted by the person or the people that are doing that. One thing that I think is really important here is that we know that patients with sarcopenia, we know that women, we know that many of our patients have very low serum creatinines. And what might be a normal serum creatinine for most of us, maybe a 1, for some of our patients, a 0.1 or a 0.2 is actually normal. And so we don't accurately reflect renal dysfunction in many patients. And since all of these classes depend to some degree on renal function and actually creatinines, that can be an issue. So I just wanted to mention a couple of other papers that I thought were interesting, but I'm not going to go into depth on here at all. Women benefit more from having a potential living donor than men. And this paper actually looked at women who actually were listed for transplant, somebody identified as being a potential living donor, and they actually found that those women were actually more likely to get transplanted with a deceased donor than if they didn't have a potential living donor. And one of the thoughts there is that if a patient comes into a program with a potential living donor, they get their evaluations quickly, they get very, very meticulous, stringent sort of workup early on, and probably get listed earlier. NASH-related cirrhosis is not associated with lower patient eligibility for transplant compared to other liver disease etiologies. I think that's important, especially since many of these patients are obese, and I think there has been a disservice to obese and even in some cases morbidly obese patients in not transplanting them, even though they might have a pretty good chance of doing well after transplant, and there's sort of evolving data on that. There was the International Multicenter study on the outcome of local regional therapy before transplant for HCC, extending the Milan criteria. I think that certainly worldwide Milan criteria are still used. In this country, you can only get a MELD exception if you're within Milan criteria. And there are many patients that actually would benefit outside, and trying to figure out who those patients are. Liver transplant in the PEth era, the phosphatidyl ethanol is a alcohol metabolite that we check, and unfortunately, many of our patients are coming back with sort of low levels, and sometimes that means that they've actually been drinking, and sometimes, you know, I suppose there are some false positives. And so what do we do with these low levels? Certainly if they're very high and they're high risk patient with a high risk history, then we get very, very suspicious. But we're finding a lot of people with this lower risk levels, and we're not really sure what to do with them. The last one I thought was really interesting: transmission and impact of donor allergies in living donor liver transplantation. It's well known that that allergies can transmit with a liver from the liver to the recipient. And certainly studying this kind of thing is really only feasible in living donors because you can go and do testing on the donor before or after the transplant. And there was some thought that maybe if you transmit donor allergies, you might actually increase the risk of either antibody-mediated rejection or T-cell mediated rejection. And that actually didn't pan out in this study. It also may have, though, some impacts in terms of the donor allergies, certainly about drug metabolism, about actually transmitting drug allergies. But again, in this particular study, they actually didn't find any transmission. So in terms of the questions, patients who are Hep B surface antigen positive undergoing liver transplantation, they get lifelong treatment. Usually, most programs will give either a nucleoside or nucleotide agent starting right after transplant. Most of them were on agents before their transplant. We tend to use the same one they had before. And then based upon their Hep B DNA levels right before their transplant, we tend to dose the HBIG for some period of time, which kind of varies between programs. Historically, if a patient was co-infected with Delta, they would get lifelong Hep B immunoglobulin, because if you have breakthrough surface antigen, then you're at risk for developing recurrent Delta. There was a paper actually showing that that's not necessary, that risk is very low, even if the recipient becomes surface antigen positive. But I think it's still the practice of most centers to be using lifelong HBIG in those patients. African Americans have a lower risk of dying from end-stage liver disease compared with other races. The answer is that is false. They have a higher risk of dying, even though they have a higher rate of being transplanted. So there really is there's a need to make sure that we're getting patients evaluated properly for transplant, and that they have access. Frail patients should be excluded from liver transplant due to poor outcomes. I think the data support that intervening on frailty and transplanting them sooner after identifying frailty may actually improve liver transplant outcomes. And we shouldn't necessarily exclude patients, but we need to intervene on them. And certainly there are some patients where they're so frail and their outcomes are likely to be so poor that we actually have to deny them. But I'm hoping as time, as we move on and move forward, that becomes less and less important. And so I have a lot of references here, and I will provide all of these references. And I chose to put the references at the end just to not clutter up the slides.